Thank you for the invite. I will just go through quickly with my topic. I'm going to speak about the follow-up and the toxicity with the SRS for brain metastasis. SRS has been now a standard for a limited brain metastasis for 1 to 4 lesions. The use is exponentially increasing. It has shown excellent local control and the cognitive outcome as compared to the whole brain RT. Coming to the follow-up, why we need to do the follow-up after SRS? We need to do follow-up for the response assessment, follow-up to evaluate a new lesion in the brain, which is outside the SRS treated area. Also, we need to evaluate for the radiation necrosis, which is one of the commonest toxicity post-SRS. We need to evaluate a neurological status of the patient, serial contrast MRI with spatial sequences, and the PET scan to rule out and differentiate between the recurrence and the radiation necrosis. A CT scan is usually not recommended in the follow-up for assessment, either for a new lesion or a differentiate with the radiation necrosis. MRI is the golden for imaging modality for the evaluation of brain metastasis. The common sequences are the plain post-contrast spectroscopy and the perfusion. The enhancement is in the treated area is because of the disruption of the blood-brain barrier. The common causes are the tumor recurrence, radiation necrosis, ischemia, or infection. The conventional MRI cannot distinguish between the differential diagnosis. How to differentiate between the recurrence and the radiation necrosis? The features which points to the radiation necrosis are the development of the lesion away from the primary site, the multiple lesions, the area of the atrophy, and the lesions in the contralateral hemisphere. These criteria are more useful for the primary brain neoplasm, which is localized to the one area. For coming to the brain mets, so post-treatment evaluation, we need to suspect the radiation necrosis if there is an enhancing lesion which develops in the bed of a previously treated lesion, a development of the lesion in the area of the leukoencephalopathy, a relatively little mass effect in the size of the lesion, and the lesion is the peripherally enhancing with central necrosis. So there are different patterns of enhancement like a wavefront pattern or a cheese pattern, which points towards the radiation necrosis. Also, there is associated hemocytic and the calcification within the treated area. Coming to the spatial sequences, the MR diffusion is one of the modality which can differentiate between recurrence and the radiation necrosis, where diffusion can be either restricted or facilitated. The ADC will give or apparent diffusion coefficient will give an idea about the characterization of the disease process. The highly cellular tumor have a restricted diffusions like a lymphoma or the melangiomas. Coming to the perfusion, perfusion is very important for differentiating a recurrence in the radiation necrosis. In the perfusion sequence, we get an idea about the RCBB values. The high RCB values is indicative of a recurrent tumor, whereas the low values less than 1 usually denotes a hypoperfused area and points towards the radiation necrosis. Another is the K-trans factor. Again, it gives a calculation of the tissue permeability. The high K-trans factor is associated with the recurrence of a tumor, and the low values are points towards the radiation necrosis. Last is the MR spectrosequence. The spectroscopy shows the different peaks in the chemical structure of the brain with the Na, choline, create, and the lipid lactate. We need to calculate the different ratios, and the ratios of elevated choline Na and the choline create favors the recurrent tumor and the radiation necrosis. As vis-a-vis, Na create ratio is lower in the radiation necrosis part. The last, when there is a dilemma on the MR, when there is a different, we cannot differentiate between the recurrent tumor and the radiation necrosis, then the PET scan or a metabolic scan can help. The FDG has a less sensitivity for a brain because of the very high uptake in the normal brain tissue. So the newer traces like a methionine or FBPA can be used to differentiate between the recurrent tumor and the radiation necrosis. Coming to the response assessment, the RANO criteria have been developed for the brain lesions. Initially, the trial used to do a response assessment based on the RECIST criteria. The main issue with the RECIST is that they consider a brain and the extracranial sites as a single compartment. So you cannot differentiate between the response in the intracranial and the extracranial part. So also there is in the last 2-3 decades, a lot of targeted therapies has been started, which has a significant brain penetration and the effect on this brain. Uh, Third thing is usually in all the trials, the symptomatic brain mets patients are excluded. So the Reno BM criteria were developed. This uses the brain as a separate compartment. It has been derived from the Reno high-grade glioma and the RECIST criteria. It uses a single measurement because the brain mets are usually spherical. A clinical status and the use of steroid is included for the response assessment, and it is useful for defining and standardizing the response in the clinical trials. It proposes the different endpoints for early phase and the late phase trials. Also, it gives the guidelines for the trials which uses the systemic agents which have a brain penetration or effect on the CNS, like to determine the potential of the CNS activity of the drug, understanding the disease response both intra and the extracranially, and for the high-risk patients. These are the criteria for which the response assessment can be done. Coming to the toxicity, the SRS is a highly conformal and dose distribution. There is a rapid fall off. The toxicities are limited. It depends on the location, volume, and the dose of the tissue, dose of the prescription. The acute toxicity associated are the mild headache, heaviness, nausea, and the patchy hair loss. The lead toxicity, the commonest is the radiation necrosis, hemorrhage, and the cranial nerve toxicity if the location is very close to the cranial nerves. Coming to the radiation necrosis, which I will describe in 2 or 3 minutes. It is a necrosis resulting from the therapeutic radiation to the whole brain, partial brain, or post SRS. It is a frequent and the well-recognized toxicity. The incidence is reported is 5 to 50%. Most of the radiation necrosis remains asymptomatic or radiological. The symptoms again will depend on the location of the tumor, like a headache, fatigue, nausea, or imbalance in the seizure. There is no single modality to differentiate between the recurrence in the radiation necrosis. A clinical pulse, brain biopsy, or the imaging over a follow-up gives an idea about this. Pathophysiology is the disruption of the blood-brain barrier and the occlusive vasculopathy, which gives rise to the radiation necrosis. There are the different literature and the studies which have given an idea about the constraint or the dose-volume relationship, which points towards the higher incidence of a radiation necrosis. It is the idea for the single fractions or a fractionated SRT treatments like a 3 fraction or a 5 fraction. So different volume criteria which needs to be taken into consideration. Again, in the first lecture, Dr. Tanvir mentioned, for a single fraction specifically, if the V12 gray is more than 10 cc volume of a brain minus GTV, then it's always better to do a fractionated treatment to reduce the incidence of radiation necrosis. The other factors which has been reported are the gamma knife has a higher incidence of a radiation necrosis, the PTV margins. If you use higher PTV margin of 3 mm, which has a higher risk of necrosis as compared to 1 to 2 mm PTV margin, inhomogeneity. So the lesser of the marginal dose and the higher central dose reduces the risk of radiation necrosis. Location of the hotspot, more than 105 between the GTV and the PTV increases the risk of radiation necrosis. The systemic agents like a TKI or immune checkpoint inhibitors again are associated with a mixed result. Sometimes some studies says that it has a higher incidence of necrosis. Coming to the management, the steroids are the cornerstone. You need to start with a steroid, try to start as low dose as possible and minimum duration so as to reduce the side effects. The other things are the management are the bevacizumab. The associated toxicity needs to be considered because bevacizumab has the issue of hypertension, proteinuria, the wound healing complications. Also, if there is a hemorrhagic mets, then the bevacizumab cannot be considered. The surgical management are the reserved for the patient who are not responding to the conventional steroids and the bevacizumab. The principle remains the same. You need to remove the enhancing tumor with the surrounding area, which might be causing the edema. If patient has received the bevacizumab, then the surgery should be deferred by around 4 to 6 weeks. The last refractory cases, the hyperbaric oxygen therapy remains one of the options. Coming to some special locations where there is a high risk of some other toxicities like a cerebellum, there is a risk of having a obstructive hydrocephalus post SRS. The only factor which donates a high risk is the previous resection. Brainstem is a critical location. The SRS on the brainstem areas are associated with a toxicity of around 7 to 8%. The toxicities are a bit different with the hemorrhage and the hemiplegia or a weakness in the motor system. The factors are the high volume marginal dose in the pre-SRS, the whole brain receive. For a multiple brain mets SRS, again, it can cause a higher toxicity because the volume of the irradiation increases. Coming to the SRS and the immune checkpoint inhibitors, some studies shows that the patient who receives the immune checkpoint inhibitor prior or after SRS to the brain mets has higher toxicity as compared to the patient who have not received the immune checkpoint inhibitors. Last is the financial toxicities. So if you assess the financial toxicity for the patients who are undergoing SRS, so they have shown that almost 25% of the patients had some kind of financial distress when they were undergoing the SRS, and significantly around 60% of the patient wanted to discuss with the doctors, provided the treatment is not getting changed. Coming to the conclusion, the SRS is the integral in the management of brain metastasis. It has shown an excellent local control and cognitive outcomes. The follow-up with the neurological status and the serial MRI are needed. We need to differentiate between the recurrence and the radiation necrosis, which is sometimes challenging. The toxicities depends on the location, volume, and the dose of prescription. The symptomatic radiation necrosis is fortunately uncommon, but can be managed with adequate treatment. A careful dose prescription and the plan evaluation can minimize the toxicities. Thank you.
Thank you. Thank you, Nikhil.
Thank you, Nikhil, for this enlightening us with the toxicity and follow-up schedule. I would like to